Hello again. So today we continue with the uh, with the other parasites. We have studied the protozoa before, which are unicellular, and now we shall study the worms actually, which are large and multicellular. And under the worms, which are called in parasitology the helminths, we have got the flatworms and the roundworms. And under flatworms, we have cystodes or tapeworms because the adult worm looks like a tape, like the scotch tape if you want. Tapeworms, and then the trematodes or the flukes, which are leaf shaped, like a leaf of a tree. And then we have the roundworms, which we shall study in the next lecture, and those are referred to as nematodes. Okay, here we have got further classification or division of those, but let's go forward and start with the cystodes or the tapeworms. Like you see on this picture, the blue worm here is a tapeworm. You can easily appreciate that, and the arrows point to the beginning of those tapeworms or the scolex or the head. So the cystodes or tapeworms, the worm is made up of a scolex or head. It can be armed with suckers for attachment to attach to the intestinal mucosa, and in some species a rostellum with hooklets. We shall see pictures of those. And the neck is the area, of course, behind the head where formation of new segments or proglottids takes place, a process called strobilization. Now, the body is a series of proglottids or segments that is referred to collectively as the strobila. So the body of a tapeworm is referred to as a strobila. And those are pictures. Here we see the scolex and the neck behind it. And in a schematic drawing, we see the scolex again with the rounded suckers in this case. And it has got a rostellum at the tip of the head with hooklets in there. And then the segments which are behind the neck, those are called the proglottids. Some of them are immature initially, then they become mature, and then they would be gravid proglottids. Okay, a scanning micrograph of the scolex, the rostellum, and the hooklets. Characteristics of the cystodes or tapeworms: the species are flattened, dorsoventrally and elongated. The size is microscopic to several feet long, and we shall see some examples. They are covered by a cytoplasmic tegument comparable to a skin, okay, a cytoplasmic tegument versus a cuticle, a thicker cuticle of nematodes or roundworms. They have got no body cavity and no digestive system, hence they absorb their nutrients from the surrounding lumen of the intestine. Excretory system containing ciliated cells referred to as flame cells extending into excretory tubules. So they have got a rudimentary excretory system. And reproduction, all tapeworms are hermaphroditic. All tapeworms are hermaphroditic. And what this means is that it means that every worm, and here every segment of the tapeworm, has the characteristic sex organelles which you can read in this slide. And this is a picture of the worm at different levels of its body or strobila. Here we have the scolex and the segments that are produced from the neck behind that. Then we have immature segments, mature segments or proglottids, and then the gravid proglottids. And what you see inside in the gravid proglottids is the uterus that is full of eggs. Okay. Now, those tapeworms belong to different families or groups, let's say. We have the order of Cyclophilidae, and under Cyclophilidae we have got the Taenia species, and this includes the pork and beef tapeworms of humans. Hymenolipis species is another tapeworm that is called the dwarf tapeworm, and it's less important. Echinococcus species, this is the cause of hydatid cysts, which are fluid-filled, space-occupying lesions that we shall describe in detail. The order of Pseudophilidae includes Diphyllobothrium latum, again Diphyllobothrium latum, which is the fish tapeworm. Let's see. The Taenia species, pork and beef tapeworm, the intermediate hosts are the cow or the pig, and they are called Taenia saginata for the beef tapeworm and Taenia solium for the pork tapeworm. A tiny trick that I would like to teach you is that Taenia saginata contains geme for saginata, and it comes from lahm al-ajl, beef tapeworm ajl, geme for saginata, geme for ajl. So the remaining one will be Taenia solium, which comes from pork meat, from the pigs. Okay, those are pictures that you can easily understand now. A tapeworm in the hands of a medical worker or researcher working on those worms. And this is the simple life cycle. People get infected by ingesting the cysticercae in the meat of infected animals, and you can see here the cow and the pig actually for beef meat and for pork meat. Once the cysticercus is ingested, it will be liberated by the digestive enzymes and in the stomach and in the small intestine. The scolex evaginates and it attaches itself to the intestinal mucosa and starts to enlarge and live there. And as it matures, we know that those are hermaphroditic, so fertilization will take place, the eggs will be produced, and they will be shed to the outside, and the Taenia produces a lot of eggs actually. Those eggs, if the human stools containing those eggs contaminates pastures of those animals, the pig and the cow, then while they are grazing or foraging for food, they may ingest those eggs which develop into cysticercae in their meat, and hence the cycle will be completed. Taenia saginata, the beef tapeworm, transmission is by eating raw beef meat. The adult lives in the human intestine with little abdominal symptoms. Taenia solium from the pork meat, transmission is through raw pork meat. Again, the adults live in the intestines with mild abdominal symptoms. And this is the infectious part of for Taenia. Whenever we eat raw meat, we may get infected by Taenia because we would be eating the cysticercae, which you see on the right-hand side of the slide, the lower portion, the lower picture here. You see the cysticercae compared to the head of a matchstick. Those are cysticercae. They are not easy to find, but of course, they can be looked for in a slaughterhouse by experts examining, inspecting the meat for certification for human consumption. Now, again, the diagnosis is by stool examination for the eggs of the adult form. So we look for the eggs to diagnose infection in humans. The eggs by stool examination. Treatment is praziquantel, 1 dose of praziquantel. This is the recommended treatment, but it's not available in Beirut and in Lebanon, so we go back to the older treatments of niclosamide or the second best albendazole. Prevention, sewage treatment. Of course, if people don't defecate in the field, if they don't defecate on the grass to contaminate the pastures of those animals, then they would not be infected. So sewage treatment is essential, and cooking or freezing the meat as well will kill the cysticercae and it becomes non-infectious. Okay, the Taenia eggs, those are the typical Taenia eggs. You notice that they are rounded in a way and they house an ovum inside, where under the microscope you may be able to see the hooklets, another characteristic feature. One more important feature is that there is a thick eggshell that you can see in all of these eggs, and it is referred to as the embryophore. Okay, a thick eggshell that houses the hexacanth embryo. So this is the Taenia life cycle. But one more thing, here we have got cysticercosis. You read on this slide cysticercosis. It's the same life cycle, but here we see only the pig in this picture. We see only the pig. Okay, why is this so? This is so because the eggs produced by humans, if ingested by other humans and not by the pig actually, they can develop into cysticerci in the tissues of man like they develop into cysticerci in the tissues of a pig. And actually there is a mistake in this slide, in this chart, and it's better drawn like that, because what produces cysticercosis is the ingestion of the egg that you see, the rounded egg down in this slide. This is how cysticercosis is produced. And then once the egg is ingested and the embryo is liberated, it may go anywhere in the body to be deposited anywhere in the body. It may go to the brain like you see on this slide. It may go to the other tissues or anywhere. Cysticercosis is produced by the cysticerci. You see it in pink and red. This is the cysticercus. The dark spot, the dark red spot here is for the evaginated head, actually, which exvaginates and then to continue the infection. Sorry, I was just interrupted now, but no problem. This is the Taenia egg and the Taenia cysticercus. And as written here, cysticercosis occurs specifically and only with Taenia solium eggs, which means that the Taenia saginata eggs do not infect humans. Okay, Taenia solium cysticercosis, this is for the transmission. And we have development of cyst-like larvae in the tissues of humans, clinically subcutaneous tissue nodules, space-occupying lesions 1 to 1.5 centimeters, and it can occur in the brain, neurocysticercosis, producing epilepsy, hydrocephalus, basilar meningitis as well. So neurocysticercosis producing epilepsy, hydrocephalus, and basilar meningitis. Okay, clinical manifestations of cysticercosis, you can read them here, but what I want to mention is that new onset seizures in adults in endemic areas are caused by neurocysticercosis until proven otherwise. So in the differential diagnosis, what tops the list of the differential is neurocysticercosis. When you see the picture on the next slides, you will remember that. Here we have cysticerci that are calcified in the tissues of humans. This is a picture from the atlas. And look at this picture. Here we have cysticerci, too many in the brain. This is for neurocysticercosis, and you can easily appreciate and expect that such a patient may have seizures from scars in the brain there. And in the spinal cord over the right-hand side, an unlucky patient with a cysticercus in the spinal cord. Again, another picture here at the tip of the arrow and the tip of the scalpel. Diagnosis, CT scan or MRI for tissue larval forms. Serology can be very helpful as well. Treatment, albendazole together with steroids and an anti-seizure medication, of course. Alternative would be praziquantel, and the treatment is prolonged. Okay. Hymenolapis nana is the dwarf tapeworm with a characteristic egg. This is a chart that shows you the proglottids of different tapeworms, that is the mature segments, and the scoliosis or the heads of those tapeworms. Clinically, this is less important for us. We make a diagnosis of the tapeworms by finding the characteristic eggs in the stools, not those parts of the body. Diphyllobothrium latum. Diphyllobothrium latum actually is a pseudo-phyllidian parasite. You can see that the suckers here are groove-like, okay, and this is the characteristic egg over there. Diphyllobothrium latum is the fish tapeworm. So infection is acquired by eating raw fish. And where do people eat a lot of raw fish? That would be probably in Southeast Asia and in other countries by the shoreline. Okay, the adults live in the human intestine as well. Clinically, usually little or vague abdominal symptoms. Rarely vitamin B12 deficiency is associated with Diphyllobothrium latum infection. Treatment, again, praziquantel. niclosamide can be used or albendazole. Prevention, again, sewage treatment, cooking or freezing the fish. Okay, next we go to hydatid disease. Well, hydatid disease is produced by the worm that you see on the right hand side, the lower corner, Echinococcus granulosus. So it's another tapeworm. Let's see what's the story with that. Okay, looking at the cestoda under the order of Cyclophilidae, we have studied Taenia, the pork and beef tapeworm, Hymenolipis species, the dwarf tapeworm. Okay, the last one, Diphyllobothrium latum, the fish tapeworm. And now we shall study Echinococcus species. This is the cause of hydatid disease or hydatid cysts. This is a picture of the worm. We can see easily the scolex with a rostellum, and then the neck behind it, and 2 or 3 segments behind it, 3 segments in here. Well, this is the adult tapeworm, and it occurs in the intestine of the dog. So this is a tapeworm of the dog. The adult is in the intestine of the dog. But as the eggs are produced by the worm and they are deposited in the stools of the dog, if it is a stray dog depositing eggs here and there, or if it is another dog that is not treated to prevent parasitic infection in its intestines, so it will be depositing the eggs of Echinococcus granulosus to infect humans. Those are the areas where it occurs, mostly in blue. Those are the endemic areas. Please notice that it occurs quite frequently around the Mediterranean and in the Middle East as well. So this worm, which occurs in the dog, it occurs in dogs and other canids, okay. The intermediate hosts are sheep, camels, cattle, and pigs. Those are the herbivorous animals. Accidentally, it can infect man as well. So if man comes to ingest the egg, man can be infected. So you see this life cycle, it circulates between dogs and sheep usually. In the dog, it's the tapeworm in the intestine, and in the sheep, it develops into a hydatid cyst, which you can see drawn at the left lower corner of the slide. Here we have a hydatid cyst in the liver and the lungs usually. Okay, but also man can be infected if man comes to ingest the egg. Now, how do we ingest the egg from the excreta of the dog? Of course, it can be. If the vegetables are not well washed, if they are soiled or contaminated with the excreta of the dog, we may get the infection. Children at picnics with their families, they leave their sandwiches on the ground. They go play for a few minutes and come back, pick up the sandwich, take a bite, and go back to play. So people can get easily infected, other than the vegetables, which may carry a certain risk. So the first item for prevention here I would like to stress would be to practice common sense. If the leafy vegetables look dirty, if they look to be soiled, whatever is on them, leave them aside. Maybe we can wash lettuce, the leaves of lettuce. We can wash it well, but other leafy vegetables, we cannot wash them very well. So leave it out. While selecting the parcels of those vegetables, we have to select clean and fresh-looking items, of course. This is another drawing for the life cycle. Interestingly, please look, the sheep is larger than the camel. Wow. And larger than cattle, actually, because the problem is mainly in sheep, and it's in sheep raising areas. But all of the herbivorous animals can be infected, of course, and man can be infected. Characteristics of the adult worm. The adult worm is 2 to 7 millimeters. I would say it's around 1 centimeter in size. Generally, it's about 1 centimeter in size. The body is composed of scolex and then 3 to 5 segments. And one infected host or dog may harbor many thousands of adult worms. So it can disseminate a lot of eggs in the environment. The adult worm produces eggs that are released in the environment with a wide distribution nature. Okay, they are very widely distributed. It is believed that insects like cockroaches and flies and other insects may help spreading the eggs around of Echinococcus granulosus. Okay, you can see here in a section of an autopsy dog. This is part of the intestine, and you can see a lot of whitish structures which are actually the Echinococcus granulosus adult worms. So you see dogs can be heavily infected, and in the lower panel you can see those Echinococcus granulosus adults put in a petri dish or so, and then the characteristic egg. However, the egg, although it looks like a Taenia egg, but we are not really much interested in it because it's excreted by the dog, not by humans. And what we do in clinical medicine is that we examine a human excreta, the stools of humans. Okay, the hydatid cyst. It's made up, starting from the right-hand side. The hydatid cyst wall is made up of a laminated layer, which is about 1 to 3 millimeter thick, depending on the size of the cyst. The larger, the thicker. And then there is the germinal layer, which is the dark layer inside, the germinal layer. This germinal layer is a syncytium of cells from which protoscolices will pop up inside the hydatid cyst in the fluid-filled cavity, and this may enlarge to become like daughter cysts as well, that we'll see more pictures of. Okay, here you see on the right-hand side, the upper picture is that of a laminated membrane, the outer membrane of a hydatid cyst, and then adjacent to that, at the same level, we see an opened up hydatid cyst. Below that, we can see a section through the hydatid cyst that is colored. We can see the laminated membrane very well, and then the cyst contents inside, and the protoscolices to the right-hand side. Shall see more pictures? Okay, this one here, this is a true pathologic section of the hydatid cyst. Starting to comment on the upper picture, we can see from the lower side, left-hand side, we see pink liver tissue. Actually, this is the liver tissue, and then we have the laminated membrane, which is pale in color, and inside it we have the syncytium of the germinal layer. This is the germinal layer. You notice that a protoscolex has popped up, has grown up from this germinal layer, and towards the upper left corner you can see a daughter cyst or a brood capsule. This is when it is small, it is referred to as a brood capsule. It can enlarge into a daughter cyst, and it contains multiple protoscolices. Those protoscolices are the infectious component of the hydatid cyst. And those are the protoscolices from the atlas, but this is the way we look at it because they will sediment by gravity actually. You see, hydatid cysts can become really large. Okay, please compare to the size of the hand of the surgeon. And this is in a CT scan of the abdomen of the liver. In the upper picture, we can see the hydatid cyst in the liver, as well as many daughter cysts inside it. To the right-hand side, we see a chest X-ray with a cavity in the right lung, and the arrow points to an irregular area, which is the water lily sign. This is when a hydatid cyst ruptures and the laminated membrane falls down, then it will be irregular, not like a straight line, the air fluid level, rather it will be irregular, and it's referred to as the water lily sign. This is characteristic of a ruptured hydatid cyst in the lung. Okay, again, you see hydatid cysts of the brain, and you can see to the left-hand side how large this cyst is in comparison to the hand of the surgeon. Probably it is about 10 to 12 centimeters large. This is in an MRI of the thigh as well. We can see a large structure, which is the large hydatid cyst with daughter cysts inside, which are darker in structure. This is again CT of the abdomen. We see a calcified hydatid cyst, but interestingly, the arrow points to a non-calcified, a viable hydatid cyst adjacent to it. So we should be careful when we read the X-rays. Look for everything in there. We have a calcified dead cyst, okay, but we have got another viable cyst next to it, which has to be treated as well. Okay, diagnosis of hydatid disease. The CBC can be like normal. Eosinophilia may occur if the cyst is disturbed or ruptured or leaking. The chemistry is also normal. The liver enzymes may be elevated sometimes if the cyst grows large in the liver, and usually those cysts involve the liver in about 60% of the cases, and the lungs in about 30% of the cases, and the other 10% will be distributed anywhere in the body, like 1% in the brain, 1% in the bone, 1% soft tissues, 1% the spleen. So it's like that. Serology, old serology is the indirect hemagglutination test, which has been replaced by the ELISA test, which is kind of better. Radiology, as you have seen those x-rays, the ultrasound can be very helpful. CT scan and MRI will be very helpful in staging and in diagnosing those hydatid cysts. One more thing that I would like to stress on you is that people get infected by ingesting the eggs produced by the dog. And how are dogs infected to complete the life cycle? Actually, hydatid cysts occur very commonly in the livers of sheep. So in our wrong butchering techniques and slaughtering animals by the roadside, and so whenever the meat seller finds something cystic in the liver, اللي هي سودة بالعربي, if they find a cystic structure, they cut it out and throw it away, so stray dogs will come to forage on it and they will get infected by the protoscolices within the hydatid cyst. And the life cycle continues actually. Treatment. All right. Depending on larger and larger series, it is surgery, the PER method, or chemotherapy with mebendazole or albendazole. This is hydatid cysts in the liver at surgery with traction of the liver. Okay, the PER method, what does it refer to? First, please remember that the PER method is only practiced in the case of liver cysts only, not lung cysts, not other cysts. And it stands for percutaneous aspiration, injection, reaspiration. So it is the percutaneous, that is through the skin, puncture of the cyst, aspiration of part of the fluid of the cyst, then injection of a protoscolicidal agent, waiting on it for 5 to 10 minutes to kill the protoscolices, and then reaspiration again, and repeating the same procedure twice or 3 times. Okay, and the protoscolicidal agents are like hypertonic saline at the concentration of 20 or 30%, ethanol or alcohol, okay, ethyl alcohol, ethanol, but it has got side effects. If it leaks into the bile ducts, then it may produce fibrosis and sclerosis of those bile ducts, so it has side effects. Citramide, which is a quaternary ammonium compound, which means that it is a strong detergent, like strong soap. This can kill the protoscolices as well, and it's usually used, citramide, at the low concentration of 0.5 or 1%. So this is for treating hydatid cysts if we don't want to do surgery and we can evacuate the cyst. So we practice the percutaneous aspiration, injection, reaspiration technique. Now the recurrence rate is low and it is less than 4%, usually performed in combination with chemotherapy or with medical treatment with the drugs a few days before and for 1 month after, usually. Modern management, it's surgery whenever applicable, the PER technique for liver cysts, and medical therapy can be applied, but usually it is a combination of all of those. Pre-op treatment or before practicing the PER technique is usually given for a few days, like 3 days or 4 days only, until the tissues are loaded with albendazole, and then you would operate on the patient. And you continue or you keep the drug for 1 more month after surgery. Primary treatment, like medical therapy alone, has got its indications, like in the case of small hydatid cysts, less than 5 centimeters. Those are too small to operate on, and they can be killed, and the body can take care of them with medical therapy. Multiple hydatid cysts, of course. Residual cysts after surgery. Pre-operative or post-operative medical therapy is very well applicable, as we said, in combination approaches to treat the patient. Recurrent cysts, like in the brain, bone, or soft tissue, and they tend to recur there. Always it goes with percutaneous drainage, and if other options are contraindicated, surgery or PER. Now, medical treatment contraindications are like in very large cysts, more than 10 centimeters in diameter. What will happen eventually to the cyst? Nobody knows, but the body cannot take care of it altogether. So very large cysts are better operated and removed. Cardiac cysts also should not be treated medically for fear of rupture and dissemination. They would better be removed by surgery, and known side effect to the drug also. Okay, this is for echinococcosis, E. granulosus, the cause of hydatid disease. And we have got one other important echinococcus, multilocularis. The other two are less important. Echinococcus multilocularis produces alveolar hydatid disease. And the life cycle here involves the fox rather than the dog. Okay, the fox or other canids, like you see to the left-hand side of this slide, but it's mainly the fox. And it circulates between foxes and rodents. The fox will harbor the adult Echinococcus multilocularis, and the rodents will harbor the hydatid cyst. However, farmers working in the field or hunters of foxes actually, they may get infected by ingesting the eggs, of course, and those eggs develop into cysts, into multilocular cyst, Echinococcus multilocularis in the liver. And luckily it occurs mostly or only in the colder regions of the globe, like in Alaska and in northern Russia, in northern Canada, in Central Europe. That's where it occurs. And this is a nice slide that compares the hydatid cyst over the left-hand side, which is smooth and rounded, and as you can see it now, you can read everything in it, and compare it please to the right-hand side, the multiloculated cystic structure in the liver. Actually, it grows like a tumor, which you can appreciate on this black and white CT scan, and in color you can appreciate it in this resected segment of the liver at surgery. Treatment of alveolar echinococcosis. In Japan, it occurs there. Surgical resection, of course, antihelminthic chemotherapy, albendazole usually, or liver transplantation whenever the liver is failing, actually. And this is the Central European red fox, the definitive host for Echinococcus multilocularis. A nice animal. Okay, helminthids. So now we have studied the flatworms, cystodes, the tapeworms, trematodes, the flukes. We shall go to the trematodes and the flukes. Okay, trematodes, they are called the flukes commonly, and they are leaf-shaped, like you see here. Let's see how. Okay, the phylum is the platyhelminths, the flatworms, the class Trematoda or flukes, and here we see two examples. Fasciola hepatica, which looks like a leaf, really, and then we have got the schistosoma adults, male and female. All of the flukes are hermaphroditic, except for schistosoma. So you can remember from this slide that you can see the adults of the schistosomes, and here we have got the male and the female. And the male is kind of flattened, and then it curls up on itself, and the female comes and it lays itself down in this long canal. Okay, so it lays itself down in this long canal, and they live happily together for few years, several years. It can reach up to 7 to 8 years. Okay. Go on. Here we can see the leaf-shaped structure of the flukes schematically, and also in flukes that have been isolated from patients. Now, so those flukes, the size can be microscopic to few centimeters. They are not segmented, rather they are leaf-shaped. Digestive system is present, but it's blind and rudimentary. You see, the tapeworms did not have a digestive system. So here, the flukes, they do have a digestive system, but it is blind, and it is colored in brown in this schematic drawing. And you notice that it has a mouth opening, okay, but there is no opening at the end, so it doesn't have an anus or an opening. Hence, it's a blind digestive system, all right. Excretory system occurs, and it is a rudimentary excretory system as well. Reproduction, most or all of the species are hermaphroditic except for the schistosomes, where the adult worms reproduce sexually and subsequently larvae reproduce asexually. I'll comment further on that. Okay, those are, this is just to show to you that every parasite of those is hermaphroditic, which means that it contains the characteristic sexual organelles for male and female. And this is a scanning micrograph of Fasciola hepatica. You see it has got two suckers, the anterior sucker for feeding at the tip of the fasciola body, and then a ventral sucker which is for attachment to wherever it occurs, attaches itself to the tissues to be fixed, and it lives there. Now, schistosomes. We have got some species of schistosomes. We have the important Schistosoma mansoni, then we have Schistosoma hematobium, and other schistosomes like Schistosoma japonicum, less frequent of course, and other schistosomes. This is distribution for Schistosoma mansoni in tropical and subtropical areas, and this is Schistosoma hematobium. Hematobium actually is for the urinary tract, and we shall talk more about this. You notice that on this map in Africa, there is a red line, a thick red line that joins between Sudan and Egypt. This is along the Nile River and the Nile Delta at the Mediterranean as well. This is where schistosomiasis occurs in Egypt and in Sudan. This is for Schistosoma japonicum in the Far East. For the Middle East, okay, an interesting slide that mentions, please concentrate on the diseases only. Forget about numbers and other things. But what do we have in the Middle East? The disease malaria by Plasmodium species. Okay. Cutaneous leishmaniasis. We have studied that. Leishmania tropica, Leishmania major. Schistosomiasis. And we have got both Schistosoma mansoni and Schistosoma hematobium. The hookworms. Ankylostoma duodenale, this is a roundworm. Ascaris, the roundworm, Ascaris lumbricoides. And hydatid disease, which we have just studied. Okay, schistosomes are closely associated with the aquatic environment. Why? Because the eggs of the schistosomes, which are excreted by humans, they have to go to the aquatic environment, and the meracidium, which is liberated from the egg, has to invade a snail. It has got to go to a snail host. And where are snails present? In the water, like you will see in subsequent slide. So it develops further polyembryony in the snail, and then the cercaria will leave the snails, and the cercaria, like you see here, they are like tadpoles, مثل البرعت يعني تبع الضفادع, very juvenile frogs. Okay, it carries a head and a tail. Now the tail simply is for penetrating the skin of humans, so it helps the head penetrate the skin of humans, and upon the penetration the tail will disintegrate behind, and then the head will be delivered to the circulation, where it goes eventually into the blood vessels, where the adults develop and they mature and start laying eggs again. So that will complete the life cycle. This is a more complex life cycle, but don't worry about details at all. It only shows you the different species of schistosomes and the different species also of the snails or mollusks, which house those particular species of the schistosome, and the liberation of the cercariae, which come to infect humans upon swimming in the water, upon wading in the water, upon farming and stepping into the water and the mud in those areas. Now, transmission, as I said, having direct contact with infested waters like the Nile River. Now, rivers are becoming more and more polluted, maybe, and less habitable for snails, let alone the parasite itself. so we don't know how heavily infested or infected the waters are. Our Litani River used to house schistosomes in the past, but not anymore, because you know of the problem of contamination and pollution in the Litani River. It's very heavy. Nothing would survive in that waters, I'm afraid. So this is a parasite of the blood vessels. You see in red on this slide that those are parasites which live inside the blood vessels. And it's interesting, I'll mention more. Clinical manifestations. Now, upon acquiring the infection, skin invasion by the cercaria, there will be a localized dermatitis, and this is sometimes referred to as the swimmer's itch. So if you swim in the Nile and then few hours later you would have itch in the skin with some lesions that reflect like allergy, think of schistosomiasis and dermatitis or swimmer's itch of schistosomes. Early systemic circulation of the schistosomules, this is during the time of the maturation of the parasite, while it is still enlarging and maturing before it's deposited in the veins where its destination is, and the patient would have fever and lymphadenopathy or enlargement of the lymph nodes, and this phase is referred to as Katayama fever. Dr. Katayama from Japan has described that. Then the patient goes into a chronic phase, which is largely asymptomatic, but depending on the species, the eggs get trapped in the tissues, or we say embolized to the tissues. Why do we say embolized? Because the parasites occur in the blood vessels. Like here we have got the liver. So the parasites would live in the mesenteric veins, and we shall see this on the subsequent slide. The parasites live in the mesenteric veins, and the female deposits the eggs, and those eggs are carried in the portal circulation to the liver. In the liver, they get trapped there to produce hepatic fibrosis and portal hypertension and liver cirrhosis. In the colon, some of them go to the colon to produce inflammation, polyposis, and fibrosis. And then Schistosoma hepatobium lives in the urinary bladder veins. So the eggs will be produced by the female, and with the help of a spicule, actually, they will be deposited in the urinary bladder, and there they will be expressed to the outside, and there they can predispose to infection of the urinary bladder, urinary tract infection, dysplasia of the wall of the urinary bladder, and cancer. So, Schistosoma mansoni and others, those are blood flukes, as I said. Transmission is a human contact with fresh water contaminated by stool or urine of other humans or animals for that matter. The infection can occur in higher animals. Adult flukes live in the mesenteric or urinary bladder veins. Okay, so they are truly blood flukes. They are blood flukes. Clinically, hepatic fibrosis and cirrhosis, as I said, and urethral obstruction and bladder cancer with Schistosoma hematobium. Okay, this is a geographic distribution of Schistosoma mansoni infection. Schistosoma mansoni. Okay, and Schistosoma mansoni is the cause of bilharzia. They call it in Africa around the large lake district and around the Nile River and Nile Valley. They call it bilharzia, and that was the cause of the death of the singer Abdul Halim Hafiz. Okay, why? Because he lived in a rural area initially, and upon repeated exposure to the infested water, he would have recurrent infection and heavy infection by those Schistosoma mansoni parasites, where the eggs go to the liver and they produce inflammation and eventually cirrhosis of the liver. That's Schistosoma mansoni. And this is the egg of Schistosoma mansoni with the characteristic side spicule. It's like a thorn, مثل شوكة يعني. It's a side spicule. Everything is characteristic about this egg, not to mention its size, which can be easily measured. It is oval in shape, it's a brownish in color, and it has got this characteristic side spicule. Schistosoma japonicum was drawn, the egg there, but it's less important. Now, this is again to the left-hand side in a stool examination, you can see the side spicule of the egg, it's characteristic, and what's next to it is an air bubble in there. And in a pathologic section of the liver, you can see the fractured egg. It's fractured by the fixation and cutting technique, but we can easily see the side spicule and it is characteristic. Please notice the multiple nuclei of inflammatory cells coming to the area, reflecting inflammation. Okay, and this is in a stain to show fibrosis in the liver, around the triads of the liver. Okay, with liver cirrhosis, you know that the patient will have external abdominal varices, okay, and there would be ascites in the abdomen, that is accumulation of water and fluid in the peritoneal cavity. Schistosoma japonicum, eggs in section of the colon as well. Here there are those larger darkly staining structure. Those are for the eggs of Schistosoma japonicum in the colon, and the tiny dark dots are for the inflammatory cells, the nuclei of white BCs. In the colon as well, we mentioned polyposis, and here you can see it at colonoscopy. The black structure over the right side, right lower corner, is actually the scope itself in here, not anything else. Okay, schistosoma hematobium, as I said, it is in tropical areas and around the Middle East, and this is the characteristic egg. Please notice that the spicule here is terminal rather than to the side, and this is characteristic of schistosoma hematobium species. Okay, how does infection occur? If you know German, and probably even if you don't know German, it's very easy to understand it. That boy urinating into the water and depositing the eggs into the water, the larvae will leave the egg and invade the snails at the bottom of this lake where they are playing and swimming, and then development and multiplication in the snail occurs, and then we follow the red arrows where the cercariae will be liberated to penetrate the skin of the other hosts as well. This is how infection goes on, and this is the same in English. And this is a section of the urinary bladder. We can see the eggs of schistosoma hematobium, and we can also notice the multiple nuclei of white BCs to reflect inflammation as well. And here we can see diagnosis is by finding the characteristic eggs in the stool or in the urine, depending on the species. Serology can be helpful. Actually, serology is very helpful, especially in the earlier phase, at the Katayama fever phase, the first 2 to 3 months. And also it can be helpful in the case of light infection, where it would be difficult to find the eggs in the stools or urine, so you do serology and you can find it. Biopsy, of course, can show us the eggs in the tissues like you saw in the slides. Treatment, again, praziquantel is the treatment of choice. Prevention, control of snails by molluscicides, okay, but better than that, sewage treatment and disposal, if possible. But please remember the open fields, and so they don't put latrines or toilets in the fields, so people just defecate anywhere. Well, whatever it is, people have got to be more careful about that. Well, and if people don't contaminate the water, then animals can come and contaminate the water. So they have got to be careful. Wearing thick plastic boots, like a big jazma. Okay, a thick plastic boot can be very protective, but those are not readily available in the rural, poor areas as well. All right, how can I prevent schistosomiasis? Usually in an endemic area, avoid swimming or wading in fresh water, okay. Drink safe water. This is a minor mechanism of infection, but make sure to drink safe water. This goes for anything else, better than getting gastroenteritis either. Bath water should be heated for 5 minutes at 150 degrees. This is no problem for showering. And if your friend pushes you into the water, so try to come out of the water rapidly, or they will pull you out. And as you come out, vigorous toweling, towel drying would be good, So you should dry yourself with a big towel vigorously to remove as much of the cercaria as possible so that they will not invade your skin. Whatever. Other flukes, that's for the schistosomes. Now, other flukes. All other flukes other than schistosomes, all other flukes other than schistosomes are hermaphroditic. Okay, now we have repeated that and it's clear. Also, and they have two intermediate hosts where metacercariae form on the second intermediate host. And let's see how is that done. Okay, we have Clonorchis or Opistorchis. Those are the biliary flukes. Transmission is by consumption of metacercariae in infected freshwater fish. So here what we have is that first, humans usually come to contaminate the water with the eggs of Clonorchis and Opistorchis. The merasidium leaves the egg, it goes to a snail host, it develops further, and it leaves the snail host as a cercaria. Now those cercariae will go in between the scales of the fish, and there they round up on themselves to develop into metacercariae. So upon the ingestion of those fish, people may get infected. So if the fish are ingested and they are raw, not cooked, they may produce infection, of course. Okay, adult flukes live in the biliary ducts, so this is truly, those are biliary flukes in the bile ducts. Clinically, they may predispose to ascending cholangitis or infection of the biliary tree, and they are associated with later development of biliary duct cancer or cholangiocarcinoma, bile duct cancer or cholangiocarcinoma. Those are the eggs, the Clonorchis opistorchis eggs, and you can look at the pictures. Very nice. Don't worry about details, just for your information. Okay, clinical manifestations: acute, some abdominal pain, eosinophilia may be found. Chronic, they live for years in the biliary tree, producing at times obstruction and predisposing to infection, inflammation, cholangitis. Also abscess formation, and they would predispose to endothelial metaplasia and cholangiocarcinoma. We said that. Diagnosis: stool microscopy and serology can be helpful. Treatment: praziquantel. Most of the flukes are treated with praziquantel, except for Fasciola hepatica, which we shall describe. Fasciola hepatica is the true sheep liver fluke. We have seen the Clonorchis and Opistorchis, those are in the bile ducts, but the Fasciola hepatica is in the liver, actually. And here what we have, very similar life cycle. It's for the sheep. The eggs are produced, and those eggs are deposited in the aquatic environment. The merasidium, which is the larva, goes into the snail, it develops further, and then the cercaria leaves the snail and it goes to round up as a metacercaria on water vegetations, which are taken up by other sheep, and infection goes on. So here we see the cercariae over the left-hand side and the metacercariae on the stalks of the vegetations over the right-hand side. Those are like cysts, actually, which will give infection upon ingestion. Here we have watercress. Watercress is a wild herb. بالعربي اسمها قرص عني. قرص عني. Okay, so قرص عني has been associated very much with infestation by Fasciola hepatica, and it can produce Fasciola hepatica infection in humans if ingested. And over the right hand side lower corner we can see Fasciola hepatica flukes in the liver tissue. Please notice that here we have got the fluke right in the liver tissue, without a cyst around it, without a membrane around it, nothing. So upon ingestion of the metacercariae on watercress, the juvenile parasite crosses directly to the liver, and in the liver it spends there between 1 and 3 months, developing and maturing and enlarging, swimming in the liver, producing very high eosinophilia, until it comes to be deposited under the capsule of the liver, like you see over the left hand side, or in the bile ducts like on the right hand side. So you see, this is a true liver fluke. It's correct that it occurs in the biliary tree, producing filling defects in the biliary tree, sometimes rarely obstruction, but it is also in the liver itself. It grows in the liver, and it usually likes to lie under the capsule of the liver, like you see here. So initially in the developmental phase, there would be a very high eosinophilia, but later on the eosinophilia gets normal, goes down. Scanning micrograph of the fasciola hepatica and the characteristic egg. Now, how characteristic is this egg? Just as you see it, it's oval in shape, brownish in color, operculated. It has got an operculum or a lid at one end, like you see here. And also the size is characteristic, which can be very easily measured by a calibrated micrometer on the eyepiece of the microscope. This is something that is routinely done in the parasitology laboratory. Very easy to measure the size. Clinical features during the acute phase, you can read it there. As I described to you, some fever, hepatomegaly, vomiting, nervousness symptoms, eosinophilia, all will occur. In the chronic phase, it becomes asymptomatic or intermittent biliary obstruction. Okay. Treatment here, as I said, it's not praziquantel, it's better triclabendazole. But if triclabendazole is not available, then praziquantel as a second best drug, and bithionol as well can be used, but it is less effective. So triclabendazole is the better treatment for fasciola hepatica. And don't worry about the specific treatments here. You can remember general terms only, that the flukes are usually treated with a praziquantel. But whenever you want to come to treat a patient, let's say in a couple years when you start your clinical clerkships, you better go back to the updated references and see if there has been any change in the recommendation as well. Paragonymous species, this is Paragonymous westermanni. Its bubbling name, Paragonymous westermanni. It's the lung fluke. And why is it the lung fluke? Because it lives in the lung. How is transmission? Is by consumption of the infected freshwater crabs. Actually, the metacercariae here are around the joints of the freshwater crab. Okay, now those crabs, if not well cooked, and if they are infested with the metacercariae of Paragonymous species, they can give this lung fluke infection. Adult flukes live in the lung, and clinically pulmonary symptoms may appear, or you may find it as a nodule or a mass on CT scan of the lung. Hemoptysis can occur as well. Diagnosis, examination of the sputum and stool for eggs. Interesting. You may find the egg in the stool. I leave it to you to think how would the egg of a lung fluke appear in the stools. CT or MRI can be helpful in the diagnosis, not of the head, of the lung, of course. Treatment, praziquantel again, and prevention, cooking the crab meat and sewage treatment. This is a chart that shows you to the same calibration here that you see on the left upper corner of this slide. You can measure sizes and you can estimate sizes as well. Okay, and the characteristic eggs. So those eggs are rather characteristic by sizes and shapes and other characteristics. Spicules for schistosomes as well. Again, those are live pictures, which if you want to just try to make it as an exercise for you. Again, here we see a lot of eggs of the worms that we shall study in the subsequent lectures as well. And thank you. This brings us to the end.